MGTV, η ομογένεια κοντά σας. The Hellenic Medical Society of New York.
Hi there and welcome. Tonight we are here to celebrate our annual ΜΑΙΡΗ ΚΑΛΟΠΟΘΑΚΗ event. This is one of our big speakers for the year, where we have both an educational symposium, a scientific symposium, and we also incorporate our board meeting with the General Assembly meeting to discuss future events for the year. Thank you. Enjoy. We thank you for being here. Let's get right to it. Dr. Liberis, thank you for always organizing this event and getting our speakers and awardees. And I'll have you take over.
Honored to be here tonight. This is the 4th annual ΜΑΙΡΗ ΚΑΛΟΠΟΘΑΚΗ Symposium. And this tradition began under the presidency of Dr. Nikolaos Mezidis. We were at a board meeting and everyone graciously took to the concept of having a symposium that features specifically women in medicine. So Hellenic American women who contribute to our field. And I must say most of the board was male then. We have more female participation currently. And they loved the idea. So right away there was a lot of support for this concept, and actually a challenge from Dr. Mezidis to find a female that we can name it after, since we have the Papa Nikolaou Symposium. He said, Stella, so what are you going to call this female symposium? So then began the hard work of trying to figure out a worthy, historically relevant person to name the symposium. And I was very fortunate to come across a Greek lecture. Luckily I could read Greek pretty well, at least well enough, about the history of Dr. ΜΑΙΡΗ ΚΑΛΟΠΟΘΑΚΗ. And for today, I would like to just refer to the program, and you can review that since we want to try to be more precise with our time, especially we have the General Assembly today. And next year will be the 5-year, so we'll also do something more historical about her life and tribute. So we're lucky to have their participation today as well. ΜΑΙΡΗ ΚΑΛΟΠΟΘΑΚΗ was born in 1859, and she was one of the few females that studied medicine in Europe. She received her medical degree in France. So today, in the spirit of the ΜΑΙΡΗ ΚΑΛΟΠΟΘΑΚΗ award, we are honoring Dr. Αναγνωστοπουλου, Anastasia. Dr. Anastasia Anagnosopoulos is a very loved member of our society. And has a long history of participation and a lot of friends and support, and thank you for coming to support her and her award today. She is a pathologist. She trained in Greece, and I guess because her husband, who was a clinical cardiologist, wanted to come to the States for residency, she also took to the challenge and came. And to her credit, she learned the language and then was able to be accepted in residency after only a year and a half of being in this country. She trained she had completed her medical degree at the University of Athens in Roosevelt Hospital, New York, and was chief president and fellow at Long Island Jewish with a surgical pathology fellowship in cytopathology. She has a very long and productive career, successfully overseeing as director of the clinical and anatomical laboratories in the blood bank. She's been working at St. Francis Hospital in East Hill, New York for, I think she told me, 35 years, is that correct? And has participated in other positions as assistant clinical professor at Columbia University, physicians and surgeons, as a member of several committees at St. Francis, including the Chairs Committee, the Medical Executive Committee, the Cancer Committee, the Tissue and Procedures Committee, and the Continuing Medical Education Committee. Thank St. Francis and Dr. Anagastopoulos for all the years of helping the Hellenic Medical Society to that end.
I'll try to talk to you within half an hour to give you to talk about lung cancer and give you a summary of some subjects that I thought they were very important, and also they were understanding to all of us. I'm going to talk about epidemiology, risk factors, prevention, symptoms, early diagnosis, classification and staging, and I'm going to touch histology, molecular studies, and the new targeted and immune treatments that are in place right now. I'm going to start with epidemiology. Lung cancer is the leading cause of death from cancer in the United States and all around the world. And it has been such since 1950s for men and the 1980s for women. The average 5-year survival is 16.8%. It is most common in men over 50 with a long history of smoking. Lifetime risk is 8% for men to develop cancer and 6% for women. It is more common in African Americans, more common in military veterans, and it is more common in developed countries. Risk factors. Number one is tobacco use. We know about the relation between lung cancer and tobacco use since 1929. It was for first time a German physician that published the link between the two. About 1950, a group of British physicians got together. They organized a very well thought and well organized epidemiological study, and they confirmed the link. Years passed, and in 1960, the Surgeon General of the United States came out and announced that there is a relation between tobacco smoking and lung cancer, and people should stop smoking. And here we are today, years and years later, and we still are talking and examining the fact if it is linked, if it's not linked, if there are other factors, and all of that. Let's talk a little bit about prevention. For smokers, the best way to prevent the cancer is to make them realize how serious the consequences are, to provide counseling to them, and to try to find medicine that helps them to stop the addiction, and stop the addiction. Environmental causes. They are many. The second most common cause of lung cancer is the radon gas. Radon gas is the end product of uranium. It is in small quantities. Uranium is all over the surface of the earth, within the soil and within rocks. Outdoors, the concentration is small, so it's not harmful. But inside our houses, especially basement of old houses with a lot of tubing in the ground, the concentration is high and the radon gas is harmful. Asbestos. Asbestos is another risk factor that give us different types of cancers, especially in great quantities, in high quantities. It gives us mesothelioma, a cancer of the pleura. But it gives lung cancer as well. Air pollution it's about 2%. It is calculated to be as a risk factor. But if you combine genetics and air pollution, it does become a strong risk factor as well. There are other causes, especially in the workplace. We do have chemicals, we do have minerals, we do have radioactive gases, and that also is dangerous. How can we prevent it? As I said before, I skip one slide and I talk to you about prevention. As we talked before, that's the way to treat long-term smokers. Young people, although, we have to try our best to stop them from getting used to tobacco. The other thing that we are supposed to do is to identify people with inherited defects in their genes that make them more susceptible to smoking and counseling them. For the environmental factors, the way to prophylactic, we have to take prophylactic measures in general. Now, diet, nutrition, and medicine, for years, people tried to find dietary products that they can produce cancer. Nothing has been proven so far. What the American Cancer Society is recommending, however, people to maintain a normal weight, to consume more vegetables and fruits, and products high in fibers.
And so if she could come up, we can give you our award, our fourth MAIRΗ Kalopothaki's Distinguished Female Physician Award.
This is a lot of fun, and the last talk was really terrific. I enjoyed it a lot. Still, I just want to say thank you for inviting me, and also I want to point out, you can see from the gray hairs, Stella was the trainee. So here I am to give, have 15 minutes to give you the scope of hereditary cancer testing and clinical cancer syndrome analysis now. What's new, what's going on, why we have to pay attention to this, and what we can all do to pick up these patients and why we need to pick them up. So I'm going to give you the whole thing in 15 minutes. Here is a slide I made when you go to the literature and you look, what is the risk of someone with a BRCA mutation developing cancer? And these are the studies that you can find. If someone has a BRCA mutation, a woman has a BRCA mutation, she has up to an 87% lifetime risk of developing breast cancer. So really a high risk of getting. We're looking now to primary prevention, so preventing that first breast cancer, and then I'll talk in a minute about secondary prevention, because now women live through that first breast cancer diagnosis. We don't want them brought down by a second cancer, that if we're alert, we can pick up their risk, and we can prevent it. So up to an 87% lifetime risk by the age of 70 of getting breast cancer with that mutation. A high risk, that's a little out of date, it's about a 20 to 60% risk if they have a BRCA mutation of getting ovarian cancer. So those are, of course, very impressive statistics, but it's actually these last 2 points on this slide that forced me, when the BRCA genes were cloned in the mid-90s, to start thinking about how we could intervene to help prevent these cancers. If you have a patient who has a BRCA mutation and she's had breast cancer, I'm a medical oncologist, so most of my patients in those days, they all had cancer, and I was looking at what was causing it and how could we prevent it. If they had a breast cancer and they were mutated, had a BRCA mutation, gene mutation, they had a high chance, 64% chance of a second breast cancer during their lifetime. So that second breast cancer could be prevented. That's critical now. In the 90s, when they cloned the gene, we didn't worry too much about second breast cancers. You know, the chemotherapy and the treatments we had for breast cancer were not very advanced compared to what happened after the turn of the century. In the 90s, just the late 90s, if you had a woman with early breast cancer, any breast cancer, you gave her whatever her primary surgery was, whether it was a mastectomy or a lumpectomy, with or without radiation. Then for chemotherapy, all we really had was CMF or adriamycin and Cytoxan. We had tamoxifen, and then you just crossed your fingers and sent her off and hope for the best. First, you tried to get her through that chemotherapy, and we lost people in those days to that chemotherapy because we didn't even have growth factors. So they died in the hospital with neutropenic sepsis from the chemotherapy. We hardly ever have that now. In those days, the late 90s, when you had a woman with breast cancer and you sent her off after that treatment and your fingers were crossed, 2/3 of those women died of the cancer. Now, 2016, when you have an early breast cancer and you treat them with the primary surgery, with or without radiation, then we have the taxanes, we have the platinums, we have Herceptin, lapatinib, we have a whole host of targeted therapies. Now, 2/3 of our early breast cancer patients we expect to live. So if you have now a situation where you know the woman got breast cancer and she's going to be alive 10, 15, 20 years later, you don't want her to get a second breast cancer because then you've shot your wad in terms of anthracyclines. You can't give her any more anthracycline, one of the most important drugs. She's probably resistant to the taxanes, one of the critical drugs. So you've got to get those women before they get a second cancer. So we have to identify these patients. And then this last point really changed my practice. You know, when I realized the issue here about having a BRCA-associated breast cancer patient having 10 times the risk of an ovarian cancer as a non-BRCA-associated breast cancer patient. So you think about that. You think about having 2 women sitting in your waiting room. They both have breast cancer. One woman turns to the other and says, "I have breast cancer," and the second woman says, "Me too." The first woman says, "Mine was this big," and the second woman says, "Mine too." So the first woman says, "Well, I had this many nodes, it was this biology." She goes through every single biologic, histologic, pathologic criteria that we have. And the second woman is saying, "Me too, me too, me too." Sounds to us like they have exactly the same disease. If, unbeknownst to us, one of those women has a BRCA mutation, that woman has 10 times the risk of the woman sitting right next to her of getting ovarian cancer. Ovarian cancer, which we cannot cure at this stage, it will kill her, it's a horrible death, and it's 93% preventable if we had known to pick up that patient as a high-risk patient and intervene. So it's critical that we find these women and that we intervene before they get these deadly cancers. This is just a general point about hereditary cancer testing. We now know that somewhere between 15 and 25% of all breast and colon cancers are attributable for risk of hereditary cancer syndromes. We clearly have discovered that genetic mutations associated with hereditary cancers significantly increase the risk of cancer. And it's this last point that's so important. We now have options. We have outcome data, we have clinical studies that tell us how to reduce the risk in these high-risk patients. So that's what's really changed. You know, when we started our program, we started it at Bellevue, our high-risk program, because we had money from the Lynn Cohen Foundation to help us. And
θα μου επιτρέψετε να σας μιλήσω στη μητρική σας γλώσσα για να νιώσετε και λίγο περισσότερο κοντά την Ελλάδα που την έχετε πάντα στην καρδιά και στη σκέψη σας. Καταρχήν αισθάνομαι ιδιαίτερα χαρούμενος και μεγάλη μου τιμή που βρίσκομαι κοντά σας και παρακολούθησα και πριν λίγο ένα πολύ σημαντικό σεμινάριο το οποίο δείχνει ακριβώς και το υψηλό κύρος που έχει και ο Σύλλογος, αλλά και η προσπάθεια της ομογένειας στις Ηνωμένες Πολιτείες Αμερικής και στη Νέα Υόρκη. Αισθάνομαι βέβαια και πολύ χαρούμενος γιατί πριν 3 χρόνια, στα πλαίσια της συνεργασίας, αδελφοποιήσαμε τους Ιατρικούς Συλλόγους Αθηνών και της Νέας Υόρκης της Ομογενείας και πάντα ένα γραφείο είναι δικό σας και τιμητικά αλλά και ουσιαστικά στην Αθήνα για όποιον γιατρό χρειαστεί οτιδήποτε ή γενικότερα για τη συνεργασία της Ελλάδος με τη Διασπορά. Είναι αλήθεια ότι η ελληνική ομογένεια έχει διαδραματίσει σημαντικό ρόλο στη διάσωση του ελληνισμού και έχει στηρίξει την πατρίδα μας σε όλες τις δύσκολες στιγμές.
MGTV USA. Οι δραστηριότητες της ελληνοαμερικανικής κοινότητας με βίντεο και πλήρες ρεπορτάζ. Επισκεφτείτε την ιστοσελίδα μας mgtvusa.com. Καλύπτουμε καθημερινά τα γεγονότα στην Ομογένεια.